Hello everyone and welcome to today's Facebook Live. I am Dr. Shivani Chandan, consultant obstetrician and gynecologist at Aster Hospital, and I have with me.
Hi everybody, I'm Dr. Smriti Nayak. I'm a consultant obstetrician and gynecologist, an infertility specialist and laparoscopic surgeon at Aster RV Hospital in JP Nagar. So today's topic we'll be discussing on recurrent miscarriages. And I'm sure a lot of you are very keen to know, what is this terminology, what are the causes. We get a lot of patients in our OPD who have suffered from this condition, and they sometimes are pretty clueless about how to go about it. So to start off with the basic, how do we define what is a recurrent miscarriage?
Okay, a miscarriage by the term itself means that if you've lost your baby before the 24 weeks of pregnancy is called miscarriage. And the incidence of having a miscarriage is around 10 to 20%. But when this miscarriage happens recurrently, the term recurrent miscarriage is used when there are consecutively 3 or more pregnancy losses. Only then we use the term recurrent miscarriage, and the incidence would be anywhere between 2 to 5%. The problem is that this condition is not addressed very well. There are a lot of misconceptions surrounding this term. A lot of people don't know what to do. It's very distressing, and that is why we are here today to discuss the causes and how to go about when you are diagnosed with this condition. So coming to the causes, what causes recurrent miscarriage? So the most important cause, Smriti?
Correct. So we start off with the medical conditions, which most commonly we tell our patients that may be the cause is the genetic disorders. So almost 75% of couples have one missed abortion or they lose their first pregnancy, and most common cause is the genetic cause. This can be because of an abnormal fertilization of the egg by the sperm, or some sort of a wrong or abnormal sperm has fertilized the egg. So it leads to the formation of an abnormal embryo. So the pregnancy comes positive, but it doesn't grow. So it's kind of like saying it's sort of nature's way of taking care of something that may have been abnormal, and it sort of just takes care of itself by getting terminated, or the heartbeat not coming, or it not growing very well, and not according to the gestation age that it should. So this genetic disorder or genetic causes can be investigated, and we need to also see, the main thing is when we see more than 2 losses, we first try to check on the parents. We see if they have any sort of genetic abnormality. Also, we send them to a genetic counselor to see if we can sort of see the family tree, and if there is any genetic disorders in the family, to look for any chromosomal disorders in the family. Apart from this, we can also test the products of conception. We can test the karyotyping of the products and see if there is any genetic abnormality found there. So that sort of confirms our assumption that, oh, this was because of a genetic abnormality. And hence the prognosis sort of improves when the products of conception have an abnormality. We're thinking, okay, this is a sporadic mutation. If the parents are all normal and there's a genetic abnormality found in the products, that means it was just a sporadic mutation, very low chance of recurrence, and it shows a good prognosis for the subsequent pregnancies as well. So to sum it up, genetic causes are the most common cause of recurrent miscarriages, and it needs to be investigated. Many a times patients have 2-3 abortions, and then they assume, they actually say, oh, you know what, doctor, I had some physical activity, I traveled, so probably that's why I had an abortion, or I lifted something heavy suddenly and I started bleeding, or they told me that maybe have been the reason, so don't get investigated. But that is not true. Please make sure you visit a gynecologist and get yourself tested if you have had this condition. So moving on to some more causes, right? We do know of many other reasons other than genetic disorders. So Dr. Shivani will elicit a few more.
Coming to another important and treatable aspect of recurrent pregnancy losses, which is immunological causes. When I say immunity, it means it's how the body responds to any infection or any unknown foreign object by producing antibodies. So this is how the immunological system of a body works. So when you have a condition called APLA stands for antiphospholipid antibody syndrome. This is a condition in which the body produces antibodies against phospholipids, which are found on the blood vessels. So this again leads to inflammatory process or formation of blood clots, which can lead to miscarriages. We especially suspect APLA if you had a previous history of any thrombotic episode, like if you had blood clot, a stroke in the brain, or if you had a blood clot in the lungs, any vascular event, that gives us a high suspicion of APLA. Further to that, clinically, if you've had 3 consecutive miscarriages before 10 weeks, or 1 miscarriage after 10 weeks of a morphologically normal fetus, or 1 preterm delivery before 34 weeks, either due to high BPs or the growth being restricted, or any placental issues, that is when we suspect this condition called APLA. So if we suspect it, there is treatment, and we can diagnose it easily by doing a blood test. So this blood test checks for 3 antibodies, which are anti-cardiolipin antibodies, lupus anticoagulant, and anti-beta-2 glycoprotein. The thing about the blood test is, just because one report comes positive, we do not come to a diagnosis of APLA. Like I said, it's an inflammatory process, and certain antibodies can be present transiently. Therefore, we can only diagnose this when we repeat the test 12 weeks apart. We do one test, if it's positive, we repeat it after 12 to have APLA. So if you are diagnosed with this, then the treatment is very simple and there's no need to worry. So it has good prognosis. Apart from APLA, there are other immunological causes. Some are inherited. If you have any inherited thrombophilias, sometimes there are a number of conditions, if I go on listing, like protein C deficiency, protein S. So if you have any inherited causes, these also will be investigated for and treated. The treatment is very simple, that we'll come to it again in the end. Apart from immunological causes, there's a very, very important factor, which is the anatomical causes, which I think Smriti will talk about now.
Okay. So anatomical causes we would want to talk about more when it comes to the second trimester losses. First trimester, the pregnancy is still okay, it is sitting snugly inside the uterus. The anatomical causes, we mainly talk about the cervix. So cervix is the structure which is the mouth of the uterus. It is what keeps the pregnancy inside and safe. It is what keeps shut till the labor pains start. Now, if there is any sort of uterine abnormality or anomaly because of which the implantation or the space inside the uterus is not enough for the baby, the cervix may give way and open, and the patient may have a second trimester loss. Now, it's too early for us to try to salvage the baby if there's a delivery at 20 weeks. Also, they're more predisposed to getting leaks, like the membranes rupture also can happen. So the most common uterine anomaly that we can talk about here is uterine septum. So it is a proper structure. It's a septum is nothing but a fleshy mass which is sitting right in the middle of the uterus. So it divides the uterus into 2 halves. So the pregnancy sort of grows only in one part, and sometimes if the blood supply to the septum is not good enough, it doesn't give good blood supply to the pregnancy as well, and that's why it leads to a second trimester pregnancy loss. So with septal resection, which I'll talk about again later, the treatment can be done. The second most common anatomical abnormality which leads to recurrent miscarriages is the cervical incompetence. Cervical incompetence is diagnosed, after a pregnancy loss, unfortunately. Even though, however strictly we keep checking the cervical length, we don't, put a stitch for every patient. So a cervical stitch is put when we detect a short cervix. So very few lucky patients are there who keep coming for regular visits, and we check the cervical length, we note that it is short, and we put the cervical stitch. Otherwise, most of the time the patients present to us with bulging membranes, and the fetus is already in the vagina, and there's very little that we can do. So cervical incompetence needs to be diagnosed correctly and treated as well before she conceives again in the second pregnancy, because if they again get pregnant and come, it becomes more challenging. And there are 2 ways in which we can treat cervical incompetence, which I will elaborate on later on. Okay. Apart from this, there are certain other conditions that a woman can take care of even before she conceives to prevent these recurrent miscarriages, like certain hormonal disorders. Can you elaborate on that?
Most of the time, like Smriti said, patients come to us after conception, and this is where we stress on preconceptual counseling, because sometimes you may be having a medical condition like diabetes, as simple as diabetes, or thyroid issues which go undiagnosed, and then you come with repeated abortions because you've not got it tested. So something as simple as diabetes, if untreated, can lead to very high sugars, if you have, can lead to recurrent abortions. The second being thyroid. See, thyroid, when we say just because you've done a TSH and you say it doesn't work like that, if you are positive for thyroid autoantibodies, then you're very, very prone to have recurrent abortions. So there's a whole panel that has to be done and not just TSH. So if you're positive for thyroid and autoantibodies, we are very careful and we add certain other extra medications so that the immune response is reduced and you don't end up with recurrent miscarriages. So these are simple tests that are done and can be treated to avoid miscarriages. Apart from this, certain
I'd also like to add here about the ovarian reserve. So a patient who has to get her hormones tested, if there is an advanced maternal age and then you're planning to conceive, please come down and get your thyroid antibodies tested. And if it comes positive, it also sometimes we see simultaneous low ovarian reserve. And this in turn also leads to increased chromosomal abnormalities in the formed embryo, which in turn leads to more percentage of miscarriages. So ovarian reserve also plays a very important role in terms of hormones, which needs to be tested before you plan to conceive.
So apart from this, certain environmental factors, those studies show that they may not really have any effect on pregnancies. We have seen that, excessive smoking or drinking alcohol and lifestyle changes can go a long way in reducing the incidence of recurrent miscarriages.
Correct.
So moving on, so though the definition says that recurrent miscarriages means 3 or more abortions, so do we wait for a patient to come back after the third abortion to investigate?
Not really. So after 2 abortions itself, we try to be a little more proactive because it's quite traumatic for the patient to go through so much. And sometimes they've even given up on it. They're like, oh doctor, can I even conceive? Can I even take a baby to 9 months? So we don't want them to go through so much. And sometimes even patients after even just 1 abortion come down and say, let's get it investigated. So, we are more than happy to give them answers because these investigations are easily available. They are a little bit on the expensive side, but if it gives us answers, then nothing like it. So after 2 abortions itself, it's always good to come down and get yourself investigated and start off on the prophylactic meds.
So if you've come back with 2 abortions, then there are basic tests that we would do, like a genetic test. If luckily you've come to us at the time of a missed abortion, we could send that product itself for karyotyping. We would individualize your age. We would look at various factors before deciding what to test and how to test. So definitely sending the products for karyotyping based on that report, or if you don't have the products, then directly parental, that's the mother's and father's karyotype. And the APLA test, we don't do it in pregnancy. That's a very important factor. We do it only between pregnancies. We can get false positives and false negatives during pregnancy, and hence it has to be done in the interval period. So we do a basic of these endocrine screens, thyroid, diabetes. So these are all negative, which is the case in 50 to 60% of the cases. There is no cause detected. So what happens if no cause is detected? How is the prognosis? And
so in patients where absolutely no cause is found, actually the prognosis is better. So we sort of know that genetically they're normal. They don't have any thrombophilias. They don't have any hormonal disorders. So we make sure we screen them for everything. And we prophylactically start them on certain medications which will help them continue the pregnancy. The most common drug you all must have heard of is ecosprin. So ecosprin is a blood thinner. It is started from the time that they start to conceive or they plan to conceive, and it continues even all throughout pregnancy, at least definitely until the heartbeat comes. So this drug sort of improves the blood supply. It thins the blood. It is very safe. It doesn't have any major side effects. It improves the blood supply going into the uterus and prevents any sort of unknown factors or something that maybe we've just missed out to cause a miscarriage. Apart from that, we also give progesterone supplements to support the pregnancy. Now, progesterone again is in different forms, which I don't think we need to elaborate in this session. It can be in the form of injections or tablets, but we give them progesterone so that it sort of helps make the uterus remain quiescent, and it doesn't cause pains or just some sort of little bit aches and pains, which can again lead to a threatened abortion and such things. And this sort of covers the empirical sort of a treatment. We put it like a blanket treatment for most of our patients.
I think another important investigation also is a pelvic scan. When we talk about the anatomical factors, this day and age, we have wonderful scan machines with 3D scans available. So we would do a transvaginal scan. Many people, have this anxiousness as soon as we say transvaginal scan, but it gives us very, very accurate results. And with 3D ultrasound, we don't even need MRI nowadays to diagnose uterine anomalies and to, look at is it an acute uterus, is it a septum? Further, after doing a scan and coming to a diagnosis, if the patient has a septum or if they have an acute uterus, what would we do?
Yeah. So in terms of management of these uterine anomalies, septal resection is advised. It's a very simple procedure which is done hysteroscopically. Okay, there are no cuts usually involved, but if we do want to do a laparoscopy along with the hysteroscopy, that's usually how it goes. So there will be small keyholes on the abdominal wall through which we put a camera in and see the upper surface of the uterus, and from below we put a camera inside to see the uterine interiors. So through that we can see the septum, and we do a septal resection. If it is a very thick septum, it takes a little bit longer than usual, and the patient needs to be admitted for at least a day and be observed. And the septum is cut usually using scissors, and this helps in widening the cavity. It makes it more spacious, and subsequent pregnancies have more space for it to grow. Although studies do show that septal resection is not proven to prevent any other miscarriages from happening, but if that was the only reason that was found in that couple which has had recurrent miscarriages, then why not? It may help them. At least mentally they're also at peace that there's no septum inside. Apart from that, there is also cervical incompetence. Okay, do you want to elaborate?
Cervical incompetence, like we said, we may miss it in the index pregnancy, because they don't, unless we're doing serial, suspecting that you have a uterine anomaly, and we do serial scans. So what we would do for cervical incompetence is a simple McDonald's cervical stitch. It's called McDonald's, but it's a simple cervical stitch. It's a daycare procedure. Mild anesthesia is given, and a stitch is put around the cervix. The cervix is the mouth of the uterus, and a knot is tied to hold the cervix closed. Most of the time, I would say 60 to 70% of the time, this vaginal cervical stitch helps. For certain people, maybe 35 to 40% of them, in spite of a vaginal cervical stitch, they may still go on to have a leaking and a preterm delivery. In such cases where there is a failed vaginal stitch or there's refractory cervical incompetence, we may need to go ahead and do a trans-abdominal cervical encerclage. This is a simple procedure done laparoscopically. We do it only laparoscopically. Good old days, they would put a big incision and cut a lot of blood loss, recovery time. But now we do it laparoscopically. A small tape is passed around the cervix. This is done abdominally because the stitch is put higher up, and this prevents any abortions or preterm deliveries due to cervical incompetence. Once the stitch is put, patient, this is usually again preferred to be done between pregnancies. I know you may be surprised and think, what if there's an abnormality, or what if there's something wrong? But it's easier when we do the procedure before pregnancy. Suppose you've conceived but had a previous failed vaginal stitch, we can still do this laparoscopic cervical encerclage almost up to 16 to 18 weeks as well. That is 4 to 5 months as well. Once the stitch is put, pregnancy continues as it is. But if you do a trans-abdominal stitch, we may need to deliver you through, we will have to deliver you through a cesarean. But we leave the stitch in situ itself so that it can help with your future pregnancies as well.
Yeah. So a common question we get is, once the stitch is put, how will I conceive? Because the os is tightly shut. But then we always make sure we leave little bit of space so that allows the sperm to enter. Or if a patient has to have an IUI or an IVF also, there is a space. It's not so tightly shut that there is nothing going in or out. We leave a little bit of space, so that amount of space is there for trying for pregnancy. And we've had patients who have conceived. We've done more than 15 to 20 cervical encerclages in Aster RV laparoscopically, and they've all had successful pregnancies. Moving on to the genetic part. So I just wanted to add also that there is a possibility of doing something called pre-implantation genetic screening. Now, in patients in whom there is a chromosomal abnormality found in the parent, and we want to detect if it's there in the embryo, right? So these patients are advised, because again, if they conceive naturally, we don't know if that particular egg or sperm was again abnormal and whether that embryo is normal or abnormal. So we advise them to go for pre-implantation genetic screening, PGS. And in this system, we sort of make the embryos ready and we take a sample of few cells and send it for testing and see if those cells have the genetic abnormality. The embryos which come out to be normal are the ones which are transferred, and the abnormal ones can be discarded. Other than this, if let's say the patient has already conceived and come also, and we still don't know like what's happening, we can advise for prenatal tests like chorionic villus sampling, which will detect certain genetic abnormalities when we take a sample from the pregnancy itself, and we get to know at least a little earlier if there is again the same problem in the current pregnancy or not. Further on, we can do something called amniocentesis, where a little bit of fluid is removed from around the baby and that is sent for testing. So in these two processes, we can again detect for any genetic disorders in the ongoing pregnancy as well.
Additionally, I think another thing that most parents, they have this misconception is, doctor, I look normal. Why do you think I have a genetic problem? Or, I don't think there's a genetic issue at all. So what I would highlight here is certain people with balanced translocations, that is where the genetic material is switched. If they are balanced, they do not look abnormal and they are normal. Only when they have another child, that when they conceive and the embryo may have unbalanced translocation, which may result in recurrent miscarriages. So even though you look normal, you may be a carrier of small translocations, and that is why even if you're normal, we should go ahead and do a parental karyotyping.
Especially if it's a consanguineous marriage. If you've been married to a relative, a close relative, please be aware that the genetic, if you've had recurrent miscarriages, please get investigated. There is usually some sort of genetic abnormalities found in the fetus.
So APLA, suppose you're when we're talking about the treatment, I think we missed the treatment of APLA. So if you're diagnosed and have high titers of these antibodies on 2 consecutive tests, then we would, and also if you have any of the inherited thrombophilias, the treatment remains the same that as Dr. Smriti mentioned earlier, aspirin, we would give you up to 150 milligrams. Along with that, we would give you a blood thinning injection called low molecular weight heparin. The benefit of giving you low molecular weight heparin is that we don't need to go on screening you, doing blood tests and checking your bleeding time, clotting time, PTA, PTTs. You can take this injection daily up to 34 weeks, and it has helped so many patients conceive and so many patients reach term and have uneventful deliveries. So that is a cause that can be treated and has very good prognosis.
Right.
So also, when we have had unexplained recurrent pregnancy loss, we have seen that TLC, tender love care, goes a long way. Sometimes it's only stress that is causing recurrent abortions. So a lot of support to the couple, to the pregnant lady, from the husband, from the family, goes a long way in avoiding recurrent miscarriages, especially when they're young and there's no cause detected. Then I think TLC plays a huge role in avoiding recurrent miscarriages.
Yeah. Yep. So that sums it all up. I think we've been quite comprehensive. We've been very brief and not tried to throw a lot of medical jargon at you guys. But we are more than happy to answer any of your questions. Please leave your comments in the comment section below, and we'll definitely get back to you on this. Okay. Thank you so much for listening in. Take care.